Good evening, good morning, depending where you're calling in from. You might be potentially watching this non-live, but right now we're live, and it's a pleasure to be here with two very, very well-known and capable orthopedic surgeons, Neil Saran and Uni Narayan. I predict this webinar will become the definitive resource for supracondylar fractures. So I'm extremely excited for everyone to be here and to hear them two talk. I'm going to move very quickly through the intro slides because I want to hand it over to both of them. Dr. Narayan's at the University of Toronto, full professor there, and Dr. Saran's a colleague of mine and I would say a little bit of a mentor to me. I did residency with him. He's a very, very good friend, and he's here in Montreal at McGill University. The financial disclosures were mitigated by the AO prior to our webinar. AONA is an independent nonprofit surgical specialty society dedicated to improving the care of patients with musculoskeletal injuries. We do not endorse nor promote any commercial products, and equipment here is for demonstration only. Webinar faculty. So this is a webinar on pediatric supracondylar humerus fracture. It's going to be quite practical, and I think it's going to be very helpful for surgeons treating these patients. At the end of this session, you should be able to interpret an injury radiograph in patients who have sustained a supracondylar humerus fracture. You should be able to list closure reduction tips and tricks, and also be comfortable in describing and accepting appropriate reduction parameters, and also discussing potentially what matters to the patient as well. And always this pulsus limb, which makes most of us quite anxious. You should be able to handle that algorithm. So I'm going to end in a couple seconds. We're going to have Dr. Narayan first, then Dr. Saran, and then likely back to Uni, potentially back to Neil. We'll see how much time we have left, but hopefully wrap this up by 9 p.m. Eastern, so about 1 hour. There's some upcoming webinars in September, femoral neck open versus closed reduction, and in October on a medial elbow. So stay abreast with those webinars. Thank you very much. I'm going to stop sharing and I'm going to pass it over to Uni. Thank you everyone for being here. And again, feel free to ask questions in the Q&A. Looking forward to the talks.
Thank you, Mitch. Great to be on this webinar with you and Neil. My name is Uni Narayan. I'm in Toronto at the Hospital Sick Children, University of Toronto. These are the learning objectives that just go into a little bit more detail. You know, how do you assess a supracondylar fracture? You should be familiar with some kind of radiographic classification that can allow you to make decisions. How to do a close reduction and fix a supracondylar fracture through the percutaneous technique, what the indications for an open reduction are, and the management of the pulseless fracture, and of course, tips and tricks to make some of this stuff a lot easier. So the mainstay classification is a modification of the Gartland classification. And it really divides into 4 types. There's type 1, which is the undisplaced fracture. There's the type 2, which is displaced, it's hinged posterior, either without or with rotation, which is 2A and 2B. Type 3 is displaced completely, and this can be either an extension type, as you see in this picture, or a flexion type, as you see here. And the type 4 is a displaced fracture that can go either into extension or flexion. It's often an extension type fracture, which during the course of your reduction, you convert to flexion type because you've hyper-reduced it. So that's very unstable and becomes a type 4 fracture. So how is this classification useful? There are 3 questions you got to ask. First, does the fracture require reduction? Yes or no? If it does require a reduction, does it need fixation? And then when and how soon to go to the operating room to go ahead to do that reduction fixation? And that depends on the pulse and the perfusion of the hand, the neurologic status, and the skin integrity. So here's a framework. So I've divided this essentially into two types. Reduction needed, yes or no. When it's undisplaced, it's pretty clear, no reduction is needed. Any of the others, 2A, B, extension type, 3, or flexion type, they're all displaced. They all need a reduction. The method of reduction depends on whether it's an extension type or a flexion type. The question next is what fixation is needed. Clearly, if it's undisplaced, that does not require fixation. A cast can be applied in about 80 to 90 degrees of flexion, and that's monitored to ensure the fracture doesn't displace. If it's reduced, my algorithm, a simple algorithm, is to go ahead and fix it to ensure it stays reduced for the remaining 3 weeks of time so that there's no risk of it losing reduction. The typical fixation is percutaneous, either lateral or in some occasions crossed K-wires, and sometimes there are other techniques as well. So the third question then is, when should we do this? And there are 3 time points. One is emergent or immediate, and that's in the context of no pulse and no perfusion to the hand. If there is no pulse, but the hand remains well perfused and it's pink and warm, or if there's an impendent compartment syndrome, that's urgent. It's nice to go right away, but you have 3 or 4 hours in which to intervene. It's somewhat urgent. That's within 6 to 12 hours if the fracture is open, the skin is threatened, or there's a nerve injury. And for all others, it's less urgent, and ideally sometime within the next 24 hours would be ideal. And that's what most cases of displaced supracondylar fractures are. The direction of the fracture displacement guides your reduction. So let's take a look at this. In the 3 planes, the coronal, sagittal, and the transverse plane, there are either translations or rotations. So let's look at the coronal plane on the AP view. You can have either a lateral or medial translation, and the rotation is in either varus or valgus angulation. In the lateral X-ray, which is the sagittal plane, you can have either anterior or more typically posterior translation, and then extension or flexion. That's the rotation. In the transverse plane or the axial plane, you cannot see the rotation, but you can take it for granted that the vast majority are internally rotated. The distal humeral fragment is internally rotated. And of course, the translation is shortened, so it migrates upwards. So if you think of all of those things, if you look at this X-ray, it's medially translated. It's in valgus, it could be in varus. It is posteriorly translated. It's an extension, it's shortened, and it's internally rotated. And those are the 6 things that you have to reduce during your reduction maneuver. The direction of displacement is also related to the injury to the soft tissues. The location of the ecchymosis is very helpful. So here the ecchymosis is completely anterior. So you can think of what injuries are at risk, immediately anterior. If you've got an extension type with medial translation, as you do in this situation, then it is around the anterolateral spike here that the soft tissue is at risk. And that is a radial nerve injury, which you can then examine for a sensory-motor deficit. So for medial translations, the radial nerve is at risk. If you've got a lateral translation, it's the median nerve and the brachial artery that are at risk. And an extension type, you can get a traction injury to the motor branch of the median nerve or the anterior trochleus nerve, which is just a motor injury. And then inflection type fractures are more likely associated with ulnar nerve injuries. So here is the setup for a close reduction technique. You're going to the operating room, the patient's held supine, the head is at the level of your hand or extension board, which is radiolucent to allow you to get good visualization of the elbow. I like to bring the C-arm parallel to the table from the distal end so that you can get an AP view here. And back here, it's clear so that if you want to get a cross-stable lateral, you can rainbow this C-arm underneath the arm board so that you can get a good lateral view, especially in the situation of a unstable fracture or a flexion type fracture that Dr. Saran is going to talk about. The reduction technique. If you think of those 6 types of displacement, the 3 translations and the 3 rotations, you're going to tackle each of them in turn. So remember, the fracture is foreshortened. So the first, it is also internally rotated. So in the first maneuver is to hold the humerus in some amount of internal rotation while you supinate the forearm. Supinating the forearm is externally rotating the forearm, and while the elbow is relatively extended, the olecranon of the ulna captures the olecranon fossa of the distal humerus and corrects that internal rotation of the distal humeral fragment. Okay, so the forearm supinated with elbow extended, while the humerus is kept in neutral, like this, to correct the internal rotation and to restore the carrying angle, which is the normal amount of valgus. So now you've corrected that as well. In this case, there's medial translation. If there's medial translation, you want to correct that before you do further steps of your reduction, which means you're pushing on that distal humeral fragment from the medial side over to the lateral side. You're then applying longitudinal traction to correct that shortening, to pull that fragment out to length. While maintaining that longitudinal traction, you've got your thumb applying an anteriorly directed force on the olecranon or the distal humerus to correct that posterior translation, while you press down on your fingers on the distal end of the proximal humerus here. So an anterior, a posterior force here and an anterior force here. And then while maintaining longitudinal traction and pushing anteriorly on the olecranon, you then flex the elbow to correct the extension of that distal humeral fragment. Once you do that, here are the steps one at a time to demonstrate that technique. If the fracture was displaced laterally, then pushing it from the medial side is not going to pull it in this direction. You need to switch hands so that your, in this case, right hand is up here and your left and your left hand is in the other direction, so it is actually correcting that lateral translation. So this will be on the other side. Here is the sterile setup. I usually do the reduction after we've prepped and draped. Some people do the reduction before and then hold the arm in that flex position to go ahead and do the fixation after prepping, but it's better to do it I think it's more efficient to do it this way and cleaner. You then get your AP X-ray, it's called the Jones view, to look at your anterior and posterior columns and the column views. And then you rotate externally at the shoulder so that the forearm and the arm are rotating together. You don't want to lever your forearm because if it's an unstable fracture, your fracture is going to slip off. So you're going to rotate this at the shoulder in order to get your lateral view to assess that you've got it well reduced. Once you've established that, you can go ahead to do your pinning. Now, if the fracture is unstable, then rather than externally rotating at the shoulder, you can rainbow the image intensifier underneath the table. And in that flexed position, you've not rotating the shoulder, you can get a cross-table lateral view, which will give you an image like this before you can then proceed with your fixation. If you do set up the image intensifier that way, it's sometimes helpful to take a K wire to mark a line of the humerus on that lateral view. So use a marking pen so that you can then estimate what plane your pin should be in when you're placing them percutaneously, as you can see like I've done here. The preferred direction of KY fixation is from the lateral side to avoid an injury to the ulnar nerve. And most fractures can be treated in that way. I use 1.6 KYs for children under 8 years of age and 2 millimeter KYs for children greater than 8 years of age. The first lateral wire is low and more transverse into the medial column, and your second wire is directed more vertically into the lateral column. So these are divergent pins to get a good spread at the level of the fracture site. you want to stabilize both the medial and lateral columns. There should be good spread at the fracture site between the pins, and you want to engage the medial cortex. So one rule of thumb is to imagine a midline, an imaginary midline here vertically, and your pin should cross the fracture site on either side of that imaginary midline. If necessary, you can put a third pin in order to accomplish adequate stability. You then check your lateral view. You remember to rotate at the shoulder externally with the humerus and forearm held together. Ensure that the pins are in both the fragments, and then flex and extend the elbow under fluoroscopy to check that your fixation is indeed stable. Here are two absolute requirements. At the end of your fixation, you should check your clinical alignment, and that is, have you restored in full extension the normal carrying angle? There should be a few degrees of valgus that you should see. And preoperatively, you could have checked the other elbow to figure out how much valgus that needs to be, because what you're trying to do is prevent a cubitus varus from developing. The second thing is to ensure that that alignment that you've achieved is going to be maintained for the 3 weeks that you're going to immobilize this in a posterior splint. And that is ensured or guaranteed if your fixation is stable. So your second rule is, under the image intensifier, flex and extend the elbow to ensure that the fracture is stable. In the literature, more recently, there have been techniques to stress the fracture. Now, you can do that, but that's not really necessary, because in the posterior splint, the fracture is never going to be stressed to that extent. Just flexion and extension should be sufficient. If the pins don't bend and the fracture remains where it is, well aligned, then you've achieved those objectives. So you can see this here in full extension and in flexion. The fracture hasn't moved and the pins are in good position. If the fracture has moved or unstable, you can add a third pin or replace any marginal pin and recheck your stability. So what are the indications for crossed K wires or putting in a medial wire? So in some instances, the orientation of the fracture may be oblique so that it's higher on the medial side. Under those circumstances, it's very hard to get two lateral pins that can achieve the objectives of stabilizing the medial and lateral column adequately. So you'll put one on the lateral side to stabilize the lateral column. And in this circumstance, you need to put a medial pin in, and to achieve that sufficient gap or distance between the two pins at the fracture site. Now, to do that safely, you can make a small incision over the medial epicondyle to ensure the nerve is not in the way. You put your pin in directly over the medial epicondyle, and before you advance the pin, you extend the elbow so that the nerve falls away from the pin. You can also do that percutaneously if you've got the experience of doing that, but a safer way is through a small incision. So what is a satisfactory reduction? So following a close reduction in percutaneous fixation, what is the amount of residual displacement that you can accept that is compatible with an excellent outcome? In other words, if there is some residual displacement, should you keep on trying to make that more perfect? Or is there a time when you can say that's enough because you can still get a perfect outcome? And if we can answer this question, you will have fewer manipulations, shorter operative times. You will decrease the rate of your conversions to an open reduction because of your misapprehension about what is required or what is a sufficient reduction. So to try and make it perfect, you don't get a close reduction. You go and you convert an open reduction. It's good to know how much you can accept. And this will avoid some unnecessary secondary procedures because you think that that's unacceptable. So we've done a prospective longitudinal study looking at photographs and radiographs. This manuscript is currently under review, but based on this study, we have demonstrated that a residual displacement of up to 30% of medial and lateral translation. It says 15% here. It's actually 30% of lateral translation or medial translation. Up to 30% of anterior translation or posterior translation is acceptable, provided the anterior humeral line passes through the capitellum. It should not pass anterior to the capitellum. So on the lateral view, even if there's some residual posterior translation, if your anterior humeral line passes through the capitellum, forget Bauman's angle. It's hard to measure on your C-arm. If your carrying angle looks good, and that's a visual assessment, which is easy to assess clinically. You can assess all these off the fluoroscopy and visually for your carrying angle. If you meet those criteria and your fixation is stable, so the intraoperative clinical assessment of carrying angle is good and the quality fixation is good, then those criteria is still compatible with a perfect outcome, which means it will look good, it will feel good, and at 12 weeks, they will have restored full range of motion and normal use of the arm. The only caveat is if they've had a nerve injury, they're still recovering from that, but that has nothing to do with your acceptable reduction technique. So you don't need a perfect reduction is the bottom line. Beware, however, of certain circumstances. So this is a fracture that looks minimally displaced, 2 different fractures, but look at the medial impaction right here. That medial impaction doesn't look too displaced. You may be tempted to treat this closed, but that may end up with a cubitus varus because you didn't appreciate that medial impaction has actually altered that carrying angle from a valgus into a varus position. So watch out for that. So the reduction parameters, aim for perfection by all means, but you should know when to quit. There's no need to do an open reduction or try to improve reduction with multiple attempts at close reduction if the alignment meets the parameters that I just described. And we think that these findings will be a practical guide to surgeons, which might result in fewer open reductions and less time to achieve a close reduction without compromising the outcomes. So at this point, I'm going to stop sharing my screen. I'm going to hand over to Dr. Saran, who's going to talk about some tips and tricks to complement what we've talked about here to achieve a good close reduction under difficult circumstances, before I come back to talk about the indications for open reductions and the management of a pulseless supracondylar fracture.
That's great. Thanks, Uni. Neil Saran from Montreal, as Mitch introduced us earlier. A question for you before we move on to the tips and tricks. The Bauman's angle sometimes, or the carrying angle really, because you're looking at it clinically, sometimes I find it's challenging because you got that, the more medial of the 2 pins that you're putting laterally, sometimes blocks the olecranon from allowing the elbow to fully extend. And how do you manage that situation where you're not 100% sure about the carrying angle when you can't get it fully extended?
Right. So that's an excellent question, Neil. The 2 lateral pins tend to block full extension. However, you can bring it to fairly close to full extension. Any flexion of the elbow, even slight rotations, can make it look like an excessive valgus, excessive varus, which is why the Bauman's angle is so unreliable. So I think that if you've done preoperatively an assessment of the contralateral side, you can flex it to about 20 degrees and say, all right, this is what it should look like in this situation, and that's what I'm trying to match here. You can always, when you're in doubt, take the drapes off the other side, take a look at that in that relative similar amount of flexion to see that that's matched. And if it is, you're going to be fine.
Yeah, I like it. Great little tip and trick there. And it's nice to know that 30% of translation, either in the anterior posterior or the medial lateral plane, really doesn't have an effect on those outcomes. And at the end of the day, it's really about, does your anterior humeral line touch the capitellum, and have you gotten the patient out of their varus or valgus, right? And those are usually fairly easy to achieve. Oftentimes we're left chasing the small translation or tiny little angulation on the radiographs that we're looking at. So
Correct.
very important.
I will also say one thing that was missing in those parameters was the rotation. Now, it's very hard to judge the amount of residual internal rotation in your fragment. And what our study shows is that, again, it doesn't really matter. If you've got stable fixation and restored the carrying angle, then whatever residual rotation you have is fine. It doesn't cause a problem. The problem is, if you do have a malrotation, it's harder to get stable fixation because your distal humeral fragment is on a knife edge there. It's actually harder to get your pins adequately across the distal and proximal fragment. So that's why you do need to correct that rotation. But if you are not fully corrected and you've got stable fixation and your carrying angle is fine, then you're okay to accept it.
Yeah, great points. So we're gonna just go into a few little tips and tricks that I've kind of learned over the years, things that have helped me get a slightly better reduction, take them from that borderline, do I need to open, to, oh no, this is okay now. And the thing you're going to find is that all these cases and the tips and tricks are older. It's not that 5-year-old that you're looking at here. It's more the 8-year-old, the 7-year-old, the 9-year-old, the 10-year-old, and those are where those tips and tricks they come into play. And, if you get these 2 X-rays and you show them, I think, to a junior colleague or a resident, and you ask them which one do you think you're going to have trouble with, I think a lot of people are going to say the 5-year-old. Whereas, for us, I think we're going to look at it and say, I'm more worried about that 8-year-old with that lateral that looks like a type 2, but I know it's not because of the AP. So the AP is way off and the lateral isn't. I'm really scared about that 8-year-old. That looks like it might turn into a flexion type, a lot of instability. Whereas a 5-year-old, I think the periosteum is so thick, you're just going to pull on it and you're going to do those maneuvers and everything is going to replace. And that's kind of what you see with these cases. And it's not always the case, but I worry about those older kids. So anticipating the challenge is I think very important when you're walking into this. I don't want to be thinking, oh yeah, slam dunk, type 3, I'm just going to go in, pull on it and put the pins in and that's it. I want to go in knowing which one I might struggle with so that I can have everyone in the right mindset, from people that are assisting to the anesthesia team to the nurses that are helping out. So when do I anticipate that there might be a challenge? Well, older age. So these 6 and up, 7 and up. When I start to see oblique fracture lines, shear patterns. When I see that the coronal plane deformity is much worse than the sagittal plane deformity, like the case I just showed you. When I see a brachialis sign, when there's comminution on one of the columns. Those are all kind of things that point me towards a more challenging case. So really, with these, you want to be mentally prepared and you want to walk in saying, hey, if we need to open, we need to open because that's what we need to get the result. That's okay. It's not a failure. It's a failure if you don't move to that next step. Setup, these are the slides that Uni showed you. I think this is absolutely critical for the more unstable cases, the flexion types, the bad 3s in the older kids, or the type 4s or the flexion types. You want to be able to swivel that C-arm rainbow underneath so you're not moving the arm at all. It's very, very important. I used to do everything on this image intensifier, and at some point I slowly started to convert, but I tell you that slow conversion wasn't very long. It was in the span of a few months. I went, why in the world did I ever do this the other way before? And so for me, a type 3 is automatically, I'm setting up with a hand table and I'm rotating the C-arm. The other thing is, when do you pronate versus when do you supinate? And I remember learning in residency, I was taught pretty much every single supracondylar fracture, you have to pronate it because it locks things in. And I wasn't sure, so that's what I was taught. But then I come into practice and I see these posterolateral displaced cases where whenever I pronated it, the valgus never went away and it actually accentuated the valgus deformity. And I realized, no, there's no way. You need to supinate those. And it's not a new concept. This is a very old concept. And what's happening, I'm not really sure. Is it really got to do with the periosteum tightening, muscle bounces, just the bones, the way that the olecranon and the humerus line up, and you're just forcing it into varus or valgus by rotating the forearm. But if you have a posteromedial displaced fracture, you pronate, and you can see that in this fluoro image. It's a bit of an atypical fracture, but you pronate it hard and it lines up. And similarly, posterolateral, you supinate it hard and it's going to help line this up. I mean, I had to use a little percutaneous technique here, and we'll go into that with this next case. So a Kapandji technique, intrafocal, you're using it to lever through the fracture. This is a 7-year-old, again, so slightly on the older side. And I'm doing everything, and I cannot get rid of that translation. For me, this is excessive. I need to get it out of valgus, and I'd like to decrease the translation. Although looking at Uni's numbers, you kind of think, maybe this would be okay if I just get it out of the valgus. So what I do with these, I do a little lateral, posterolateral based K-wire that's inserted through the fracture. And I'm going to, just like a Kapandji maneuver for a distal radius, I'm just going to lever that fragment, pull the proximal part out, laterally push the distal fragment medially, and also get that carrying angle restored in the same time. And you can see that happen from here to here. There's probably another image that was missing here that showed that it was a little bit worse, something in between these two. And then the lateral, we're rotating the C-arm, and you can see, it's not perfect after that initial maneuver, but we can key that in by manipulating through anterior translation, a little bit of flexion of the elbow and the distal humerus. So the Kapanji technique is very useful. Obviously, you can't just put it in anywhere. I wouldn't put this in medially if I had a patient where I needed to push it laterally, just because the ulnar nerve's there. And if I am going to do that, I'm probably going to use some other technique. So be aware of the neurovascular structures when you're using these percutaneous techniques. So this one was quite unstable, so I did go ahead with a medial pin, which I tend to use a small mini open if there's any swelling and I can't palpate the ulnar nerve. I think that's a safe way to do it. Further on the Kapanji technique, I've never used it for a flexion type. I'm not sure I ever will, because most of the time you don't have to go to these techniques, but every now and then you get one that just isn't unhinging, just not unlocking. So this one, we get it, we set it up. I've got a bump placed on the proximal, just proximal to the fracture site, and we're pushing on the humerus. Normally I don't have the elbow flex this much for a flexion type. It's usually at about 70 degrees or so of flexion. But here I'm pushing axially, and what's happening is that distal fragment is not translating. I'm actually extending the distal humerus. So I'm getting rid of that flexion deformity, but it's not translating posterior. And so with this one, no matter what I did, I could not get it to unhinge. And kind of out of the box thinking, we said, you know what, why not throw a Kapanji pin and see if we can flip it around. So here, Kapanjis posteriorly are not easy to do sometimes just because of the arm table. So I will externally rotate through the shoulder and then get my AP with a shoot through. So the C-arm is rainbowed, and I'm getting an AP image with the shoulder externally rotated right here. And then with that pin in, we're going to slowly put it in. And obviously there's a big anterior neurovascular structure here. So some people might not feel comfortable doing this, and that's okay as well. So here we managed to line that up quite nicely and get some pins in, and she healed up nice. Another maneuver is using the Esmark for milking. So this is a 9-year-old who comes in with a brachialis sign. She's neuro okay. But she's pin compulseless. She actually got a tiny little bit of open injury here. We're not going to talk about that component of it today. And you can see this is somewhat of a high supracondylar fracture, so it's going to be a challenge just getting lateral pins in here. So here, the Esmark, I'm going to show you a little video. So you can milk this. You can use 2 hands and squeeze from top down. You can milk it with your thumbs. We tried all that and it wouldn't go, and so eventually I pulled out an Esmark. We said, let's do this, and hopefully you guys see that with your web streaming. But it released as soon as the Esmark right there it pops and the brachialis releases. And then it looked kind of like this. So we said, okay, well, we still have a bit of work to do, which is usually the case when you use the Esmark. It doesn't magically reduce the fracture. It just gets rid of that brachialis poking, the bone poking through the brachialis muscle. And so here, we had a lot of trouble trying to get this back out to length and get this long anterior cortex flipped up and over the back of the posterior humerus. And I don't think this was the case where I first used the preloaded pins, but I went to it because I had a fairly junior resident helping, and I remember I'm holding a reduction on a very unstable fracture, and I'm trying to get him to get the pins started, and you just cannot get the pins in. And every time anything would happen, I'd lose the reduction. And so I was about to open. We actually had everyone open, the nurses were getting ready to open up. And I said, you know what, give me one more chance at this. We're actually going to put some pins into the distal humerus. So we spent 5-10 minutes just getting perfect placed pins into the distal humerus. And the key is you really want to place them so that you know when you get it reduced, it's going to capture the proximal fragment. So both of these pins are adequately placed, and we lined it up, and a little posterior Kapanji here, get it reduced, and fire your pins in. It takes 2 seconds. You just advance those 2 wires that are already preloaded and ready to go. Very, very helpful. If there's any one technique, that's it. It's the preloaded pins that really helps. So here's a flexion type. It's an 8-year-old, bizarre, different pattern, not the usual pattern you usually see. So what do I do with the flexion types? So typically very similar setup, hand table. I'm going to rotate the C-arm. I'm going to put a bump. Maybe might be just a little bit too big, but something that I can, it gives me some clearance over the olecranon so I can push down. I'm going to traction. My hand's usually not here. It's a little lower down on the forearm, and I'd say I'm at about 70 degrees or so of elbow flexion when I do this. I'll line up everything else. And then finally what I'm going to do is go into the rainbow, and I'm going to push down right through here to try to get rid of that flexion, any anterior translation that might be there. This one was a challenge, so we did a preloaded pin. You can actually do 2 preloaded pins here and actually use them as joysticks as well. If you still have a little bit of flexion, you can just push them down a tiny bit and advance those pins and help with the reduction as well. So another option is the ulnar joystick. This is a courtesy of one of my colleagues. I have not tried this, but he's done it a couple of times and says it has helped him. And so you can put this K-wire into the ulna to help give you a little bit of a better lever on the distal humerus itself. Another joystick technique I've used is right across the distal humerus. So this is a good one where it's in a valgus deformity. There is actually a small split, intracondylar split, and there's a fracture obliquity here. So this one's not going to be easy for lateral pinning. You could probably get one good K-wire up here, but the trouble I had with this was I could not get it out of varus. So I may have said valgus earlier, sorry, I could not get it out of varus. And so in the end, I ended up putting a pin across the humerus, where I made sure that this pin was coming out anterior, so I'm not anywhere near the ulnar nerve. And then what we did was use it as a joystick and pushed it up and got rid of that varus. And then once that's done, we fire up this K-wire, and then the second K-wire goes up, and you've stabilized the 2 condyles. The final trick that I'm going to go over is what I call a pivot pin. I'm sure someone else has a different name for it. And this is the same case I showed earlier, where I ended up somewhat employing this technique. So the idea here is I'm going to get my preloaded pins in, and typically here, it's very unstable. And you're just hoping for that one moment where you kind of get an adequate reduction. And I'm going to fire that pin in. Once I get it close, I'm just going to say fire it in. And then what I'm going to do is I'm actually going to pivot on that pin. So I'm going to further reduce while that pin is still in. And you can see I'm going to bend this pin. And sometimes it's in the sagittal plane. Sometimes it's in the coronal plane. And then I'm going to advance this pin. Here it is. And I'm going to back the first one off. I'll back the first one off and then refire it back in so that now it's holding in the position that I want. So that's that one. And then I'm actually going to kick it back to Uni, and then hopefully we'll get back to me for a final couple of cases. Just going to stop sharing. There you go, Uni.
Thanks, Neil. Can I ask you a couple of questions?
Absolutely.
On the question of do you supinate or pronate, could you clarify that you meant after your flexion? Should you pronate or supinate?
Correct. So I typically do this once it's flexed at least 90. So I don't do this in full extension, right? So this is going to happen once I'm at 90, and I'm going to go for perhaps a little bit more flexion, but definitely not while it's fully extended.
Right.
Hold on a second. Is this a secure, safe place here? This is a safe place for us 3 here. So you supinate or flex only, you supinate or pronate only after you flex the elbow?
So can I just clarify something here, Mitch? Initially, you are supinating the extended elbow in order to derotate that internally rotated distal humeral fragment.
Got it.
Once you have then put your anterior pressure on your distal humeral fragment to correct the translation and you flex, that's the question. When you are posteriorly medially translated, if that was what the original displacement was, you pronate in that position after 90 degrees of flexion or whenever. Or if it's posterolateral, you supinate. Now, this was what Mercer-Rang used to teach us as well. And in my observations, I found that there was very little correlation. Sometimes it worked according to the way that was described, and sometimes it didn't work. So I go straight into the normal position, and if there is residual displacement or a rotation that I can see based on a mismatch between the two edges, then I will do the pronation. It was posteromedial or supination and see which one works. So I'm curious, Anil, if you think
I've been doing that supination or pronation just prior to flexion in 30 degrees of extension. Then I'll, let's say, pronate, and then I'll hyperflex. So that sequence is different.
I think at the end of the day, the important point is that you're evaluating what is happening, and then you're going to act on what you're seeing. I think for me, I lean towards what Uni is saying. I'm not going to do that initially unless I feel I'm clinically looking at it and it's clearly invalgus. Well, I'm going to supinate, like, unhinge everything and get it to supinate. If it's posteromedial displays, I'd probably go up neutral, and then I'm going to, depending on what happens, I'm probably going to pronate it. But I do that maneuver when I'm around 90 or I've started to flex, typically not an extension. And
so
I think
Mitch,
it's like, it goes back to that hanging cast type of situation where, if you had distal humerus varus and you wanted to get them out of the varus, you're hanging cast at 90, right? You're gonna pronate to get them out of the varus. And I'm not sure what's happening, but it works.
right. I think the theory is that that's tightening the periosteum in that position, which creates temporary stability while you fix it. But if you've got the alignment fine and then you fix it, then it doesn't really matter at the end, what your position is. And what you described, Mitch, if you're doing it at 30 degrees of flexion, your olecranon is no longer capturing the olecranon fossa of the distal humerus. So any pronation, supination might, it might rotate a little bit, but I'm not sure. It may change the soft tissue tension, but I don't think it's changing the rotation of the distal humerus as much if you were fully extended. So that could be one difference.
I've been in awe of this webinar thus far, and I continue to learn. So let's keep going. I mean, it's amazing.
All right. Well, we've heard from Neil some really terrific pointers on how to, avoid an open reduction in the majority of cases by, applying some of those tips and tricks, because it's nice to avoid opening if you can. But at some point, you have to decide, all right, that's not good enough, and we have to open. So what are the indications? Well, if it's an open fracture, that's clearly an indication. If there's a vascular injury that requires an exploration, then you're basically opening the fracture. Okay, so a pulseless white hand, the loss of perfusion during, and we'll talk more about this, but that's clearly an indication. If there's a nerve palsy that's occurred after reduction, so you're not going to know that until the patient's awake and they have some indication on the x-ray that there's still a gap there, and now they've got a dense nerve palsy that they didn't have preoperatively, then you have to assume that have you entrapped the nerve in the fracture site, in which case you have to go back and open it. If there is a compartment syndrome that's developed because of, protracted swelling, that you come to this very late and you have to do a fasciotomy for that, under those circumstances, your fasciotomy extends past the fracture. So essentially, you're doing an open reduction as well. And then finally, if a closed reduction fails to achieve a satisfactory reduction, which if you follow the principles we've talked about here and add to that some of the really excellent tips that Dr. Saran has shared, that should be a relatively uncommon circumstance. It may be slightly more common in the flexion type, but again, if you follow the rules that Dr. Saran showed, you should be able to do it closed in most circumstances. So those are the general indications. So let's switch gears to, well, once you've got it stabilized, what's your postoperative care? The first thing to do is you're going to cut those pins short. Before you cut them short, you're going to bend them, and you've got to protect them so that they're not going to migrate in and out or piston in and out of the skin. I put a little sterile dressing of 4x4s, a gauze dressing on that, and then we're immobilizing them in a posterior splint somewhere around 70 degrees of flexion. The whole point of internally fixing a supracondylar fracture is because you can allow that elbow to be relatively extended, so and still be stable, to avoid the pressure on the cubital fossa that can result in a compartment syndrome. So many displaced supracondylar fractures, you can get a good close reduction and with flexion of 90 or greater degrees, hold it in that position. But with that amount of flexion, that soft tissue swelling in the antecubital fossa is a recipe for a high rate of compartment syndrome and or the pulse disappearing. And the moment you extend the elbow to take that pressure off it, you're going to extend the fracture as well. So that's the whole point of pinning. So then you just have to immobilize in about 70 degrees of flexion, so there's no pressure on the anterior structures. But you want at least 70 degrees of flexion so they're comfortable in a sling, so you don't want them fully extended. We typically discharge them same day, within a few hours after they've recovered from the operation, once we've established that they're comfortable in oral analgesics and their neurovascular examination is normal. We have eliminated any follow-up at 1 week because we've assessed their stability under fluoroscopy. So if it was stable there, then it's not going to move in the splint. So at 3 weeks, we take the splint off, the pins are removed. We then get x-rays after the pin removal, in fact, because we're confident that the fracture will have healed sufficiently that we're not going to extend the pin, keeping the pins in beyond that 3 weeks. We do a neurologic examination, and then we allow the patients to resume the use of arm as tolerated for activities of daily living. No physiotherapy is required. So our instructions are for 1 month, no high impact activities. So no trampolines and monkey bars, but you can use your arm to pick up your books and toys and that kind of thing. But another month for the fracture to completely consolidate and then lift all restrictions. We then do a final follow-up visit at 3 months if needed. Today, we're doing that virtually, and I'll explain what it is that we ask. All we're looking at is the alignment restored, is the range of motion restored, and is then neurologically intact. We don't get x-rays at that time unless there's a problem that is determined at that virtual visit. Otherwise, you can bring them back in to do the same check, but you don't necessarily have to get x-rays.
Uni, can I ask you a question about that follow-up timing? So I will occasionally push that follow-up to closer to 4 weeks for the older child, 8, 9, 10-year-old who's had that really unstable fracture pattern. Do you do that, or are you still comfortable at 3 weeks?
It depends on the day of the week we operate on. If it's on a Wednesday and my clinic on a Friday, that could end up being 2.5 weeks or 3.5 weeks. So of course, if it's an older child, it's a little bit more than 3 weeks. If it's, but an average of 3 weeks is fine in most of these instances. But yes, use your judgment. And it's almost, I would say more than 4 weeks for any age is unnecessary. Would you agree?
Yeah, I think 4 weeks is sufficient for all of these.
Right. So at the final follow-up, here are the questions we ask. We check the carrying angle, we're checking the range of motion, and we're comparing it to the other side, and we're doing a neurologic examination. And, here are the 3 questions that we're asking. Does it look good? And that is basically the carrying angle. Okay. Does it feel good? In other words, there's a full flexibility, there's no pain, no paresthesias, no neurologic symptoms, and they feel no weakness in that. They're using that. And does it work well? Are they regained the normal use of the arm without any limitations? And if the answer to these 3 questions are yes, yes, and yes, you don't need to get any x-rays. If the answer is no to one of these, then of course you might need x-rays. If it doesn't look good, then is it because there's a malunion or a loss of reduction? Or if it doesn't work well, you've got some problem there, you may need to investigate that further. But that's basically the questions you got to ask. And that was our outcome that we did for our prospective longitudinal study that we talked about to establish what we called was an excellent outcome at that 12-week follow-up visit. Okay. And for that study, we also got x-rays to make sure that we were not missing anything as well. But clinically, in practice, we don't need to get that x-ray. So I'm going to switch gears right now. We only got about 10 minutes left to cover the management of the pulsed supracondylar fracture. I'm not going to take 10 minutes, but there are 3 scenarios here. In all instances, there's an absent radial pulse. In scenario number 1, clinical assessment shows no pulse, but the hand is perfused. It's pink, it's warm, so there's some collateral circulation that's getting to the hand. The second situation where on presentation, the hand is pale and cool. So, there's no perfusion to the hand. And the third situation is, you start off with or without a pulse, but then you lose the pulse and you lose your perfusion following your reduction and fixation in the operating room. So let's go through each of those 3 scenarios and how we deal with them. So in the first instance, where there's no radial pulse and the hand is perfused in pink, you can start in the emergency room with assessing the perfusion. You can get a Doppler ultrasound, you can do a pulse oximetry. You can try and improve the position of the elbow to take the tension off those anterior structures. You can see that brachialis sign right here. You can see that all the structures that are draped anteriorly over that, which include the median nerve and the brachial artery, could be kinked. There could be some spasm there. So don't extend this even further, but don't flex it too much either. So maybe that Esmark maneuver or a little squeeze of the arm up top with some pain medication may just take that tension off that while you're waiting to go to the operating room. You want to go to the operating room as soon as possible because you don't want this to convert into a non-perfused hand. And so how as soon as possible? I mean, do you have to go this very minute? No, but within the next 3 or 4 hours for sure, or earlier if something changes. In the operating room, you're going to go ahead and do a closed reduction and percutaneous spinning in the standard fashion, because this could just be some spasm in the vessel. You've done your milking maneuver or your Esmark bandage or to pry that tip of the fracture here out of the brachialis so that is no longer preventing the reduction. Once you've done a closed reduction and percutaneous spinning, you're checking for the pulse. If the hand is still perfused, great, repeat, that's fine. If there's no pulse and the hand is still perfused, you repeat step 1, check the Doppler and pulse oximetry. If the pulse is present, that's great. You're off to the races. So if the pulse is absent, but it's still perfused, check for Doppler ultrasound or pulse oximetry. And if that's okay, you can just admit for observation for 24 hours. And usually, the vast majority will do just fine. On the other hand, if the patient comes in with the hand pale, white or cool, again, remember, depending on the complexion of the skin, pale and white are all relative terms. So you've got the other side to compare with. This is an emergency. Again, you start off in the emergency room with that attempt to take the pressure off the anterior structures, but you are going to take this patient immediately to the operating room, and while you're at it, you're contacting your vascular surgeon to be on standby or backup in case you need her or his help. In the operating room, you're going to do a closed reduction percutaneous spinning. You're going to re-examine for the pulse and perfusion. If you get the pulse back, you're great. If you get no pulse back, you're looking again with a feeling for for any perfusion signs of it with a Doppler ultrasound or pulse oximetry. And if the pulse is restored and hand is pink, that's great. If the pulse is not restored, but the hand is pink, that's back to situation number 1. You can observe. If the hand remains unperfused and pale despite all of these, you are obligated to explore. And if a vascular repair is needed, you must do a prophylactic fasciectomy. So let's explore this a little bit further. So here's an example, similar X-ray. You do not need to get an arteriogram preoperatively or even intraoperatively for that matter, because we know where the injury to the artery is. It may just be a spasm. It may be that the vessel is entrapped in the fracture site, or it may be a rupture. But it is through an anterior approach that will reveal itself. The damage is here. An arteriogram is not really particularly helpful. It wastes time, and even the vascular surgeon does not need it. So treat it as an emergency. And follow these particular steps. In the operating room, when you're there, try and improve the position of the elbow, take the tension of the anterior structure before you do a closed reduction percutaneous spinning, because you don't want to entrap that blood vessel further during your closed reduction maneuver. And again, as we talked about, re-examine the pulse and perfusion. If still white and cold, explore through an anterior approach. And if you end up having to do some kind of a vascular repair or a bypass, usually the ischemic time is long enough that a prophylactic fasciotomy is the wisest thing to do to avoid the compartment syndrome that has very, very likely to happen. So do the prophylactic fasciotomy. Let's look at the third scenario. So here's an example, absent pulse, you do an urgent close reduction, percutaneous spinning, or the hand was pink and warm to begin with. But after your reduction, you lose the pulse, or the hand now becomes pale and white. And what's your next step? You've already done this. There's pins in place. This does not meet the criteria for an adequate reduction. You can see the anterior humeral line is passing well anterior to the capitellum. There's still too much posterior translation to accept that, therefore, and you don't know if any structures are entrapped there or not. What's your next step? Well, under these circumstances, first, remove your pins and undo the reduction before you explore, because that may do the trick. Okay, see the pin here? This should have been taken out first before you explored, because that may have untrapped that tethered blood vessel. This may be all that's necessary to essentially to free up that brachial artery. If the perfusion is restored, go ahead, repeat your close reduction and pinning. Doppler ultrasound might be useful. If the hand remains white, then do your open exploration through that anterior approach. So here are our take-home messages. But Neil, do you want to jump in here before I end here, or shall I just give these take-home messages and then you can wrap up?
Yeah, I think so. Sure, you can go ahead.
All right. So here are some of the take-home messages. Some amount of displacement is acceptable provided the carrying angle has been restored and the fixation is stable. Okay. Unstable fixation or fixation of a malreduced supracondylar fracture can or very likely to end up in a varus deformity. We've not talked about cubitus varus. It's primarily an aesthetic problem, but that aesthetic problem doesn't look very pretty. And in some instances, we may need to correct them at some point with a corrective osteotomy. In adults, it's been associated with posterolateral rotatory instability, but we don't know the denominator. That may be a very small percentage of cases that have got cubitus varus and a malrotated. So it's that internal rotation that in combination with the varus that might predispose those fractures to posterolateral rotatory instability. So that may be just a small percentage of cases. But if you're thinking about the indications to correct a cubitus varus, that might be one of them. Monitor carefully for neurologic injury before and after treatment. Most nerve injuries are neuropraxias and will take a few weeks to a few months to resolve. If they don't resolve, then that requires further investigations and if necessary, a referral to the plastic surgeons. Learn how to manage vascular compromise, as we talked about under those three circumstances. So I'm going to stop right there and stop sharing. And we've got officially 1 minute for questions.
We had one question already. When is arthrography needed? That was a question.
Well, yeah. An arthrogram is typically indicated for intra-articular fractures where you're trying to rule out a step off after you've done a reduction, or you're not sure if there's an intra-articular extension of your fracture. But there's really no indication in a supracondylar fracture to do an arthrogram. If you have a T-type fracture, or you see an extension there and you see a little bit of displacement, you're not very sure, there may be a role to do it under those circumstances. But for the typical supracondylar fractures, an arthrogram really has little value. Neil, would you agree, or do you have any?
Yeah, I completely agree. I think I honestly don't remember the last time I did an arthrogram other than for that exact situation of where you're wondering, is there a step somewhere? And even then, usually you actually know just from that bottom of the olecranon fossa of the, just whether it's lined up or not. The only other time is in the really, really young, where you're wondering, is this a type 2, Salter-Harris fracture distal humerus? Is this a transphyseal, where I may do an arthrogram just to help get the reduction? That's about it.
That's a great point. So in a young kid, usually typically true, you can get what's a supracondylar fracture in a sense, but through the physis, and because the distal humerus is completely cartilaginous, that fragment is still articulate. It's not a dislocation, but it may look like a dislocation. And so if you do an arthrogram, you'll see that the distal humerus cartilage lines up very nicely with the ulnar and the radial head, and it's essentially treated like a supracondylar fracture.
Guys, we're gonna call it. We're gonna end on this outstanding high. This was the most thorough and comprehensive webinar I've ever been involved with. I'm already getting feedback, zooming in here on my text from people who are participating live. Thank you to the AONA crew for your support. Thank you very much for Uni and Neil for being here. And thank you all for tuning in. And everyone have a pleasant day. And that's it. See you later.